Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Consensus or Controversy. As tonight, we're going to talk about the approach to first and second line therapy of hormone receptor positive metastatic breast cancer. We have a great faculty today, Dr. Sara A Hurvitz from the Fred Hutchinson Cancer Center in Seattle, Washington, and Dr. Virginia Kaklamani from the UT Health San Antonio MD Anderson Cancer Center in San Antonio. We also recruited 4 other well-known investigators, to you and everyone else, to complete a survey, and we'll talk about the results of that as we go through the meeting here tonight. Today we're here to talk about one of the fastest moving areas, I think, in all of oncology, which is hormone receptor positive metastatic disease. So much going on there. We will be talking about the use of unapproved agents and regimens tonight, so check out package inserts for more information about specific products. Here's where we're heading tonight. We're going to start out with a little bit of introduction. Of course, oncology nowadays is biomarkers. We'll start out with that, and then we'll focus on first-line therapy of patients with hormone receptor positive disease. You know, people have been telling us for a long time, your stuff is really good to prepare for the boards, and it really is true. I took the boards just to see why people were saying that. The boards are very situation-oriented. You have a patient in this situation. What do you think's going on? What do you do about it? That's always what we do, and that's what we're going to do here tonight. We also are going to add a little bit of a new element here and see if we can get any consensus statements that I can get the faculty to agree. So I actually asked ChatGPT last night if it could come up with a good graphic to do what I want to ask our faculty, which is whether they agree or disagree with the statements I'm going to make, or maybe they're somewhere in between. So we're starting out here with biomarkers. So Virginia, here's a statement I came up with. I want you and Sara to tell me whether you agree with it, which is that mutation testing for ESR1 and the AKT pathway should be considered in any patient with ER-positive, HER2-negative metastatic disease who's got disease progression on some form of endocrine therapy, whether it's adjuvant endocrine therapy or therapy for metastatic disease, but they have progression either on the therapy or shortly thereafter. They need to be tested. I'm trying to make it simpler. I don't know if it is that simple, Virginia, but do you agree with that statement?
I do agree for the majority of patients that we should be doing mutation testing.
Sara, any thoughts about that? You know, people kind of bring up the issue. Well, I mean, I don't know if it's really true. I think we've had cases presented of people who just got adjuvant therapy, for whatever 3, 4, 5 years and had ESR1, but I know it's not very common. Do you still test pretty much most patients who've had adjuvant endocrine therapy?
Yeah, I do. We now have therapy available for patients in the first-line setting if their disease has relapsed while on or within 12 months of adjuvant AI. So I think it's important for us to know the PIK3CA mutation status. Similarly, even though the rate is fairly low, it's important to know the ESR1 mutation status.
So here's an example of the kind of graphics we're going to show you here tonight in terms of this survey that we did with our faculty and 4 other investigators. We asked them generally when did they do ESR1 mutation testing, and you can see again after disease progression, although Dr. Burstein says at diagnosis of metastasis, period. But another issue is the type of testing. Is liquid adequate? If you have tissue, do you do tissue as well? Virginia, what are your thoughts about that?
We know that at least for ESR1 mutation testing, liquid biopsy is more accurate than tissue. We could pick up around 20% more mutations. And the reason for that is that the ESR1 mutation is a subclonal mutation. That means that if you look for it in the primary tumor where you're not going to see it, it happens while the tumor is exposed to endocrine therapy, mostly aromatase inhibitors and CDK4/6 inhibitors. So if you try to do a tissue biopsy and you do it on the tissue, let's say a liver metastasis that doesn't have that ESR1 mutation, you're gonna miss it. But in the liquid, there's the accumulation of the ctDNA from all of the different mutational sites, and therefore you have a better chance of picking it up.
Sara, would you consider testing and even a SERD in a patient who'd been treated many years previously and had already, had multiple therapies for metastatic disease, maybe even chemotherapy, and had never had a SERD? Would you try testing for ESR1 and give a SERD to a patient like that?
Absolutely. Now, the chance of it working for a prolonged period of time is low, but there are patients who have an adequate performance status and are very willing to continue trying therapies. And on occasion, you'll have a patient be able to have stable disease lasting 4 to 6 months on an oral therapy like that. It's not common, but if in those situations, I will look and try if it's available.
So we're going to move on now and talk about first-line therapy. There are three major issues I want to try to tease out here. First of all, just selecting therapy, hormonal therapy versus chemotherapy and type of hormonal therapy. I want to see what the faculty thinks about the Serena-6 strategy and also the use of the inavolisib triplet in patients with PIK3 mutations. So just to get started, let's start out with a case because we actually have several cases from each faculty people to kind of get a more of a flair of how this actually plays out in practice. You've got this 56-year-old postmenopausal woman who presents to her PCP with back pain. What happened with her, Virginia?
So she had imaging done that showed that she has a breast mass, but also she has a liver lesion and bone lesion. She had a liver biopsy that confirmed that this is an ER-positive, HER2 negative breast cancer. Her NGS at the time was negative, and so she was started on ribociclib, letrozole, obviously a bone-modifying agent as well with denosumab. And she did well, and the good news was that her back pain actually improved very quickly, which is extremely important for this patient. She was able to stay on the first-line endocrine therapy for 42 months, which is surpassing that median progression-free survival that we've seen in all of these phase 3 clinical trials. So to me, this looks like a very endocrine-sensitive cancer that we had success in treating in the first-line setting.
So I want to get Sarah's take on the decision here to use ribo, letrozole, and denosumab, but how has she done on the ribo? Any toxicity at all that you can pick up?
She had some fatigue, which is pretty common. She had low ANC, but I typically don't really look at it anymore. I think it's more of a laboratory abnormality than a patient abnormality. We know that patients may have a little bit of a higher risk of infections, and so I only dose reduce if a patient has an infection on CDK4/6 inhibitor. Otherwise, I tend to keep the dose stable. So she did not need any dose reduction.
So, Sarah, I kind of wonder, this patient had liver mets, she's presented de novo. I kind of wonder, I think a lot of investigators would do what Virginia did, and obviously she did really well. But I wonder whether people, in some cases, are tempted to use chemotherapy. And maybe you can comment a little bit, because we have, I have kind of another consensus statement. I want to tell me whether you agree or disagree with this one, Sarah. Chemotherapy, parentheses, or ADCs, should not be used in a patient with a metastatic disease without prior endocrine therapy. In other words, I'm saying there's no situation where you want to start chemotherapy rather than endocrine therapy. For example, a patient like this. That might seem like kind of a radical statement, but what do you think? Can you buy into it, Sarah?
I buy into it. I'm the green guy. Fully agree.
So maybe we can talk a little bit, and Sarah, maybe you can comment a little bit. There are a couple major trials that people usually bring up. The Wright study that look at ribociclib in premenopausal women with metastatic disease, where you saw the hormonal therapy with ribo doing better, as well as the Abigail study with abema, similar kind of strategy and outcomes. Any thoughts about these trials? Were you already doing this anyhow, and any thoughts about it, Sarah?
Whenever we can use oral therapy that's better tolerated than chemotherapy when we're treating patients for an incurable condition, I think we should. And what these studies have shown is that the use of a more targeted therapy, CDK4/6 inhibitor and endocrine therapy, actually works better than chemotherapy. And in the case of the Right Choice study, patients had symptomatic visceral metastases. They were young and had aggressive disease, and the comparison arm was multi-agent chemo. It wasn't capecitabine. So I think these studies provide us really compelling evidence that we should be using the CDK4/6 inhibitor endocrine therapy for our patients before moving to a chemo-based approach.
So another issue is if you're going to use endocrine treatment, Virginia, which one? Of course, this has been heavily debated since the CDK inhibitors came out. Here's a slide actually Hope Rugo used in a presentation she did with us, as a lot of people are doing, millions of slides like this trying to indirectly compare what we see with CDK. But, I don't know if you have any thoughts about why you do see the survival benefit with ribo. Here's my consensus statement, Virginia, see if you agree or disagree. Ribociclib is the preferred CDKI for ER-positive, HER2-negative metastatic disease.
I will be the green guy as well and agree with that. It's hard to discount 3 clinical trials that are showing an overall survival benefit, as well as adjuvant data that is positive. And I think this is the issue between ribociclib and palbociclib. Now, with abemaciclib, it's a little bit different because one of the trials was probably not powered enough to look at overall survival. The numerical difference was pretty big. It was 14-month difference in overall survival. It just did not meet statistical significance. So if I had to grade them, I'd probably say ribo and abema seem to be superior to palbociclib.
So again, Sarah, any biologic, pharmacologic reason why, this comes up all the time. We have, for example, multiple IOs, checkpoint inhibitors, and sometimes you see a positive trial, sometimes negative, and everybody can't understand why, but then they use whatever IO was used in the positive trial. Is that where we're at here, or is there any sort of logic to why you see the survival benefit?
Well, trial design is certainly something that we always have to look at, and we want to be careful not to do cross-trial comparisons. That said, I fully agree with Virginia and her approach. It is compelling data. We do know that palbociclib, while it was the first to market, probably is the least potent in terms of inhibition of CDK4. Abemaciclib, probably the most potent, but the least specific. So it hits a lot of other kinases, and ribo has a lot of on-target inhibition that occurs. So I think there are some preclinical data that could explain why we're seeing perhaps better long-term benefits from ribo and abema. That said, the progression-free survival benefits are pretty similar across the board, but you just aren't seeing the benefit with palbo in the early stage setting. So I think ribo, from a therapeutic index standpoint, is probably the winner.
So Virginia Bertha in the chat room brings up an issue that I used to bring up, and Dr. Burstein always said, people don't present with brain mets. But anyhow, she says, you're a positive disease anyhow. She says, if the patient had brain mets, would you prefer abema as well as the local therapy to the brain, Virginia?
I think we have more data with abema, but I would suggest that any treatment that is active in the periphery is going to be active in the CNS, and we've seen this with ADCs, we've seen this with chemotherapy. By the time the brain develops metastatic disease, that blood-brain barrier that we all love referring to is really not. It's very leaky. And so even large molecules such as ADCs are able to get into and penetrate the brain.
So Jay in the chat room is questioning this issue of endocrine therapy as opposed to chemotherapy and says, what about true visceral crisis? You have a patient who's, maybe lymphangitic disease in the ICU, et cetera. I think we can bring in also, and you're going to start to see a little more granularity in this survey than just our 2 faculty here. So we present a situation, first of all, de novo, just similar to actually what we just heard with the case. De novo, symptomatic liver and bone mets, ESR1 negative, HER2 low. And most people are saying CDK AI, everybody except Dr. Burstein says ribo. But down there, interesting, Dr. Javari says, well, maybe paclitaxel induction followed by switch or maintenance endocrine therapy. And Sarah, I remember that's a strategy that goes way back. Using short-term chemo in a patient in visceral crisis and then bringing in the hormonal therapy. Is that something you would ever do in a patient who's in critical condition, like Dr. Javari suggesting?
Well, if they're in critical condition and we're not able to take an oral medication because they are intubated, then I think that's a really very good approach. But I I see no reason to not try an oral-based regimen in somebody who's able to take it. A lot of the chemo we give in somebody who has liver function abnormalities due to the metastases is actually contraindicated if the liver is not functioning well, whereas we have data to support using endocrine therapies. So I've not come across a patient that I wasn't able to give it to, and I've seen a lot of patients in the last year with very advanced symptomatic metastases.
So here's a similar situation of a patient with de novo disease who, instead of visceral crisis, now is asymptomatic, has bone and soft tissue. This is what we call a consensus, at least in terms of CDK. We have Dr. Burstein not wanting to commit to what CDK he's going to use, but I can tell you if we asked 20 people, we would probably see at least 18 who said Ribo. Also to point out, and I don't know if you want to comment on this, Virginia, because I wonder if people are a little confused when we say PIK3 positive and nobody says inavolisib here. We're going to talk about that later because this patient's de novo. So I don't know whether you believe whether or not actually we're going to eventually end up using it in patients like this, but do you agree that right now Inavo is not an option in a de novo situation, Virginia?
It hasn't been studied in that setting because the NAVA-120 trial was done in patients that had endocrine-resistant disease, and this patient's tumor has not declared itself yet because it has not been treated. So I agree with the CDK plus AI. As Sara mentioned, all three trials met their primary endpoint of PFS with very, very similar hazard ratios. So I think if I see a patient who's been on palbociclib and just switches care to me, I do not move on to switch them to Ribo. I keep them on the palbociclib.
So, Sara, another good question from the chat room was, so Heal, does it matter how strongly ER and PR positive a patient is if you're making a decision between chemo and hormonal therapy? If it's, there actually is I think a ER low up to 10%. I mean, how do you deal with those patients? And again, if the patient's not strongly ER positive, that make you a little bit nervous about hormonal therapy?
I think if the ER and PR are less than 10% on a soft tissue biopsy, I'm going to be concerned, especially if the disease is very aggressive behaving, high grade. I'll be concerned that this is actually not endocrine responsive disease. If it comes from a bone biopsy and the patient is known to have ER positive breast cancer in the past, I look at that disease-free interval and the aggressiveness of it, and I'll probably still use an endocrine-based approach because bone biopsies sometimes will lose expression of the antigen through the decalcification process, so you could get a faulty readout.
So here's another situation that I imagine, Virginia, we're going to see more and more of. Patients who've gotten a CDK in the adjuvant setting. In this case, we're saying they got ribociclib as well as an AI, now have a symptomatic disease. So now you have a patient who's already gotten a CDK inhibitor. Would you repeat it? Sara says yes, and other people like you say TDXD. How do you think through patients with prior CDK, Virginia? And I guess
I think this is one of
won't be too long. I was just going to say it's not going to be too long before I'm going to be asking you, what about if they've had prior G or Destin? But we won't even get into that right now. But let's just stick with prior CDK or both.
So I think this is one of the very few cases that Sara and I gave the different answer, and I think it really depends on the setting. We have very, very little data on post-CDK in the adjuvant setting and disease recurrence. And the data we have is a series from Dana-Farber that's showing that the median progression-free survival with a CDK in that first line is around 3 months, which means it didn't work. Now, chemotherapy didn't fare that much better either. And they also had patients with ADC. So I think these are just very aggressive tumors that are really hard to treat regardless of what we decide. I probably would be a little cautious in using that CDK because there was progression of disease from that CDK. But I think it's reasonable. Again, we just don't have the data to make very, very good decisions in that setting.
All right, let's talk a little bit about Serena 6. We saw more data from that at the San Antonio meeting, really cool data that I thought was very provocative, interesting after first seeing it at ASCO. Sara, here's my consensus statement, and I'm going to tell you right now that we already know that general medical oncologists and community answer this question differently than investigators. So I kind of know what you guys are going to say, but it's not the same thing that general oncologists say. Here's the consensus statement is, the Serena 6 strategy should be discussed and offered to patients on first-line CDK endocrine treatment. You still green on that one, Sara?
No, I'm red. I've turned red.
So, yeah, and most investigators are. All I'm going to say is that general oncologists, I don't know why, maybe because they're being exposed to so many situations with PFS advantage and without survival benefit. I think most people kind of know what the issues are here. They're familiar with the data. Again, it was first presented at the ASCO meeting, really showing a significant improvement with progression-free survival coming in early with camizestrant, as well as with PFS2. I think the toxicity was sort of what we expected. And this is the stuff, Virginia, I really liked from the San Antonio meeting, showing that the ESR1 mutant allele frequency goes away, which I think is fascinating. I know the discussant, Dr. DiMichele at the ASCO meeting, talked about this as molecular progression. I'm not sure that's the exact term, but in any event, why is it you don't want to move forward with this? Why do we need more data, Virginia?
Because we don't have overall survival data, and because the control arm did not receive an oral SERD after disease progression. So this is not really a sequencing trial. And as Angie mentioned very, very eloquently and in her discussion, we're comparing PFS2 to PFS3. We're comparing PFS to PFS2. So it's not really a fair comparison. Also, the cost behind this approach and the burden to the clinical staff is going to be pretty significant. And that's a big issue. Now, I think the biggest issue is the fact that the patients are going to want to do this. So they're going to come to our offices saying, I want this. I want to know what my ESR1 status is. And once it's showing a presence, they'll say, why am I continuing a therapy that I know is not working? And so I think we might be, quote unquote, forced to do it because of patient preference.
Yeah, that's why I put in my consensus statement should be discussed with the patient, because if you put it in the patient's hand, you may get a very different answer than what you think you want. Just to sort of tease this out a little bit more, we kind of said, well, somebody else sends the ESR1 and then comes to you for a second opinion. Would you switch, knowing that they have converted? And everybody says they would continue except Dr. Srigliano, who's ready to do the strategy of switching over to camizestrant. But we'll see how this, and also, in general, other than, again, Dr. Srigliano, everybody's saying they don't really want to do the routine ESR1 testing. As Virginia was saying, too, there's an economic issue, a psychologic issue. So we can see where that is right now. All right, let's also talk a little bit about the inavolisib triplet with palbociclib and endocrine therapy. And this starts to get into life on some of these new endocrine therapies. You have a 54-year-old lady previously treated who, while on 2 years of adjuvant letrozole, has a car accident, and they found to have bone mets, and she's found to have a PIK3 mutation. So what was going on at that time? I think you said this is one of the first patients you encountered in this situation, Sara?
Yeah, actually, I've been looking for a patient since the impressive INAVO 120 data came out, but I haven't found a patient whose disease recurred within 12 months or while on an adjuvant endocrine therapy. But along came this patient, and she had some obesity and hyperglycemia, had recently been started prior to this diagnosis on a GLP-1 receptor agonist and metformin. And when she came in, her HbA1c was down to 6.0 and her fasting glucose was 125. So she kind of didn't really totally meet the INAVO 120, but it was pointing in a right direction. So we felt comfortable with starting her on close glucose monitoring and starting this regimen, and actually she did fine from a sugar perspective. But the issue was grade 3 diarrhea that was really inhibiting her lifestyle, getting to the point where if she wasn't so good about oral hydration, could have landed her in the hospital. And we saw her in clinic. She told us she'd been having it for 3 days, and so we gave her IV fluids and repleted her potassium. But given this, the inavolisib is given with palbociclib, I think the GI toxicity needs to be taken seriously. About half of patients in the study, I believe, had some level of diarrhea.
All right, we're going to see what the faculty thinks about utilizing inavolisib, but it's interesting, too. Now, this lady had 2 years of letrozole, right? So, supposedly it's supposed to be endocrine resistant. I guess you'd say that it would be 2 years would be resistant. What about if she'd stopped the letrozole and had been 2 years after she completed it, Sarah? Would you still have used it?
She wouldn't have been a candidate for the INAVO 120 study, so I would not have in that situation.
All right, Virginia, here's my consensus statement. And, we saw, as soon as this data was presented, we saw the investigators changing what they do. So here's my few statements about the situation. First, patients with PIK3 mutations should be offered the INAVO triplet if they have disease recurrence during or shortly after adjuvant endocrine therapy.
Strongly agree.
For that one?
Green.
Yeah, I think here's a trickier one. I'll keep going with you, Virginia. People who are getting started on the INAVO triplet should have continuous glucose monitoring offered to them. The patch people put on their skin.
I think so. Yes. The rate of hyperglycemia is high. I think, we've learned with these agents that monitoring and actively monitoring and being in touch with the clinic and making changes to the anti-hyperglycemics that they might be and so forth is really critical for these patients to stay on these drugs.
And Sarah, one of the things that came out of this webinar we did, and the diabetologist was getting into this, is you get a lot more information about these little patches than just getting blood glucoses. You get first of all, you get hemoglobin A1C or GMI, which is the same thing. You get that continuously, but also it gives you the percent of time during 24 hours that they're within the acceptable range, which is another sort of granular. So you get much more granular information. She really encouraged people to use these monitoring. So one other consensus thing, this kind of relates back to your case, Sarah, when you realized this woman was diabetic and already had been getting managed for diabetes. So here's my consensus statement. The INAVO triplet should not be started in a patient whose hemoglobin A1C is over 8 until they have management of their glucose.
Strongly green. Agree. Yeah.
And would you like the number 8, or would you say lower than that?
I would say lower than that. In the INAVO 120 study, the 6.0 was the requirement, and some would say that the lower rates of hyperglycemia reported in that study were due to the very strict entry criteria of the study. It's important when you're looking at drugs like capivasertib and other drugs at what the entry criteria allowed as we're applying these data in the clinic.
So, Virginia, I don't know if you want to comment a little bit about the mechanism of action of INAVO and why the thinking that there may be some synergy with CDK inhibitors and the INAVO 120 study itself that we've been talking about, what it was about this whole scene that gets you so enthusiastic that you kind of consider it standard of care nowadays.
Yeah, so the INAVO 120 study looked at the triple combination of fulvestrant, palbociclib, and inavolisib. And importantly, it was palbociclib here. We've spent, 20 minutes talking about how we would give ribo, but palbociclib is an easier drug to give as far as drug-drug interactions. And so that's very important for us to recognize that if we're going to use that triplet, it has to be with palbociclib. And the results were pretty impressive. The overall survival was significantly higher, and you can see here the numbers. We're talking about about 27-month versus 34-month improvement in overall survival, and the median PFS was also higher. And I think what was surprising was that the median progression-free survival in the endocrine therapy and CDK group was much, much lower than what we've seen in these first-line trials because of the endocrine-resistant patient population that was included, which tells me how important it is to consider giving inavolisib to the patients that are eligible for the regimen.
Yeah, that's a really great point. And then in terms of adverse effects, Sarah, a lot of people had a difficult time when the first agent, alpelisib, was out there. We were really not tuned in the way we are now to some of these issues. But it kind of seems like inavolisib and capivasertib are much better tolerated. Is that your sense? And how often do you find it problematic in a patient getting inavo, for example?
I do run into trouble, I would say. Well, I've had only a couple patients on inavo. So again, I'm talking broadly, but also looking at the data. I think anywhere from 10 to 20%, maybe even higher, do require some dose holds or adjustments to the supportive medications. With inavo, I would say capivasertib. I've also had issues with severe rash in several patients that I've treated. Alpelisib was rough all around, but I would just say all of the drugs that are currently available, we see it's critical for us to be monitoring patients really closely in that first month, especially with our nurses or APPs or physicians calling and checking on patients and having very close monitoring because they can get into trouble very quickly with the sugar, the diarrhea, the rashes, the mouth sores.
I think the whole mindset about using these agents has changed so much in the last few years, and oncologists really are starting to get deeply into some of these issues. It's been really interesting in the last year because, at the ESMO meeting, there was a positive phase 3 trial of capivasertib in prostate cancer. So, we've been talking to the urologists about all this. This is like completely new to them, and they're like, oh, I'm going to talk to my breast cancer people about that. Anyhow, here's what the faculty says about the inavo triplet. As I mentioned, you can see over on the right in a patient who presents who's symptomatic. Most people are using the inavo triplet. There's one exception, Dr. Lusberg, whether it's symptomatic visceral disease or not. So we'll see where that heads moving forward. But let's move on now to second-line therapy. I'm going to throw in another one, just kind of feel good in terms of, before we get into your case here. So, Sarah, tell me whether you agree or disagree with this. In general, SERDs are more effective and better tolerated than AIs, parentheses, Lidera, I'm going to use as a reference. And in a patient who's receiving an AI who's having trouble tolerating it, the use of a SERD or giredestrant is a reasonable consideration. Are you green on that one or more like yellow or red?
I'm a little bit more mellow yellow for the first one. I'm not sure overall that they're better tolerated. I kind of, the proof of the pudding's in the taste. I kind of need to see more patients treated in that adjuvant setting with the oral SERD. But I'll tell you that I'm very hopeful, and patients who I'm treating now with adjuvant aromatase inhibitors who are really struggling with side effects, I'm hopeful that I'll have an alternative that they can try. It was interesting to see the arthralgia rates with giredestrant are on the same order or in the same range of what we see with AIs, but what I hear is the quality is a bit different than with what we see with AIs, so it may be more manageable.
So I'm curious, I don't want to get too far deep into, we spent a whole hour just on the Lidera study and adjuvant therapy, but I am curious, though, about what you just said in terms of tolerability, because I haven't heard about arthralgias with SERDs. I mean, we have a lot of, obviously we don't have experience with giredestrant. We have a ton of experience with elacestrant and now with imlunestrant. And I don't know, Virginia, to me, I know it's indirectly comparison, but it sounds like they're way better tolerated than AIs. Is that your thought?
So we've treated patients on the EMBER-4 trial that have received imlunestrant, and interestingly, they will tell you that they feel better But this also takes me back to the data we had generated, 20 years ago from switching from one AI to the other. Regardless of what AI we switched to, a certain number of patients felt better. So I feel that this is more the effect of just trying to do something new than actually the drug itself having a better toxicity profile. And as Sara mentioned, the trial showed very similar rates of musculoskeletal issues with both giredestrant and the aromatase inhibitor.
So to be continued. Let's hear about this case, though. You have this 48-year-old lady. We're starting to get now into second-line therapy. So what happened with this woman, Virginia?
Yeah, so she developed metastatic disease. She was put on ribociclib, goserelin, because she's premenopausal, and letrozole, and she did well for 35 months. But then after that, she had disease progression in her bones. And at that point, we did ctDNA testing. It showed an ESR1 mutation, and we were able to start her on elacestrant. She was one of my star patients that was able to stay on elacestrant for a long time before she had progression of disease. And I think one of the main reasons for that is selecting these patients carefully. As Sara mentioned, when you take a patient who's been on a CDK4/6 inhibitor for 12-ish months, but then have disease progression, that may not be the most perfect patient for giving single-agent endocrine therapy to. We're going to have combination data, hopefully approvals of combinations of oral SERDs that I think those patients would be better fitted for. But for this case, where you're able to stay on a CDK for that long a time, I think single-agent elacestrant is a good choice with very favorable toxicity profile.
So we'll talk a little bit about making the choice in the second line and how factoring in things like how long they've been on the first line. Sara, we have the Emerald study, the phase 3 trial that really brought elacestrant to clinical care. We'll talk about some of the toxicity that's been seen, and you have a case actually that we're going to talk about in that regard. What about this issue? You've kind of been getting into this a little bit about time on CDK prior therapy. We've had this sort of arbitrary number of a year. I think a lot of people feel it's kind of a gradient. The quicker they relapse, the more you're concerned. For practical purposes, like how long or how short do they have to be on a CDK hit inhibitor for you to start questioning whether you even want to use hormonal therapy, Sara?
Well, it's not necessarily whether or not I want to use hormonal therapy, but whether I'll rely on a single agent, endocrine agent. I really do raise my eyebrows if they benefit from a CDK4/6 inhibitor-based therapy for less than a year. I'm really concerned. And it's sort of a continuum that we look at. The longer they did well with the CDK4/6 inhibitor, the higher the likelihood that they'll do well on endocrine-based therapy, because it's a surrogate for endocrine sensitivity.
That kind of gets into also the question of single-agent SERD versus combinations. We've seen, obviously, with CDK in the EMBER-3 studies and also with everolimus as well as with a SERD. Here's more data, again, looking at the impact based on prior treatment. Really cool that they saw very similar outcomes in the real world, which, we saw in terms of PFS. And again, with the EMBER-3 study, of course, we had the combination arm, but you also have a single-agent arm, which ended up getting imlunestrant approved. Seems very similar in terms of what's seen in that situation. Here's kind of the way the faculty responds to these type of cases. So first, Virginia. And here we're varying the amount of time. So we're saying 2 years. So this patient has been on CDK for a couple of years, so maybe more sensitive, but no markers present. Most people go with everolimus and fulvestrant. Interestingly, Dr. Sirigliano, I don't know if this has to do with accessing treatment or not, but he will go even at 2 years to TDXD or capecitabine. When we bring it down to 10 months, then we see people talking about, particularly with symptomatic liver mets, you can see now everybody's saying either TDXD because it's HER2 low or capecitabine. But again, if it's not asymptomatic bone mets, several of the people, including both of you, will give hormonal therapy a try. Virginia, you mentioned about the idea of combination when you get I don't know if you think it's a better therapy, maybe everybody ought to get it. But if you do have a shorter, you're getting kind of nervous, they didn't do that well in CDK, what combination theoretically would you like to use? Would you want to use the EMBER-3 strategy, or what would you like?
I would love to be able to use the EMBER-3 strategy with imlunestrant abemaciclib in patients. Now, this has not been approved. The NCCN guidelines have included it in there, so maybe we could fight with payers that way. But the FDA did not approve that regimen. Interestingly, that regimen worked in both ESR1 positive and negative tumors, which is interesting. But I think the Avera regimen with giredestrant and everolimus, once that gets approved, would be a favorite regimen based on the outcomes that the study showed. So, we as oncologists love combinations. We are able to fight the tumor with more than just one pathways. And so I have the feeling moving forward, we'll be using more combinations in that second line than single agents.
So here's another interesting comparison. Now we're talking about ESR1 positive, PIK3 negative, sort of the SERD monotherapy situation. Typically, you see if the patient's been on therapy for 2 years, everybody says SERD, but a couple of people say maybe with abema. But now, again, on the right, you say, okay, it progressed after 10 months, and most of the sentiment, again, is towards TDXD or capecitabine. Any comment, Sara, again, in terms of in what situations you want to go with an EMBER-3 strategy?
Yeah, I actually noted I would do imlunestrant abema in this particular patient because there is an ESR1 mutation, and I found those data to be compelling. Interestingly, the comparison was imlunestrant abema versus imlunestrant. So the comparison was looking at, does abema add to the imlunestrant? And so you would expect it to work in both ESR1 mutant and wild type. So I wasn't convinced that you needed it. You needed the imlunestrant if the patient had wild type for ESR1. But this particular patient was ESR1 mutated, so I thought that would be a nice combination.
So I want to tease out a little bit about the issue of using a SERD by itself, including a choice of SERD, but also some of the tolerability issues. SERDs have great reputations in terms of toxicity, but there are things that we need to be aware of, and I think Sara's case here is a good example of it. Virginia's patient did totally fine on elacestrant. This lady had problems, 38 years old, de novo disease. What happened, Sara?
Yeah, she's a real busy mom and works full time as a paralegal, and she develops pretty persistent nausea as well as intermittent vomiting and severe fatigue. She didn't call us early on. She just sort of trucked through it and hadn't been taking her antiemetic as prescribed. So when we saw her, she'd actually lost weight, 6% of her body weight, and was really not doing well, even when she started using the ondansetron. And so she had stopped vomiting, but just was not thriving. And so we initiated a lower dose of olanzapine in the evenings, and she did much, much better. So it was a bit of a learning curve for the staff and myself in terms of some people are just more sensitive to the GI side effects of SERDs, and so they need to be really clearly educated before starting.
So that leads to another consensus statement. I want to see what Virginia thinks about, because actually an investigator on one of our programs recently was telling us that they thought that you see more upper GI nausea and vomiting with elacestrant and more diarrhea with imlunestrant. I hadn't heard that. I was curious whether you all think about it. So my consensus statement, Virginia, is elacestrant and imlunestrant are, as monotherapy, are indistinguishable in terms of efficacy or tolerability.
I would agree with that.
Either one.
Cross-trial comparisons, we hate doing them, but we do them all the time. But I would agree with that statement.
So another question I was curious about, and do you generally, is there any way you can, we hear things, about camizestrant with ophthalmic issues, et cetera, but Sara, in general, do you find it difficult to distinguish them either efficacy-wise or tolerability-wise?
I do. Without the head-to-head comparisons, I just don't have a real good feel for either of those and really can't see really huge differences in terms of efficacy or tolerability, except for some sort of I don't know, idiosyncratic, this flashing light thing that happens with a few. Like we have little
Right.
things like that, bradycardia, but for the most part, the side effects seem pretty similar.
We did a program just on ophthalmic issues in oncology. That's another area we had to get into more recently. So, Virginia, any thoughts about what is going to happen with? I was all excited when I heard about Protax. We have the BTK degraders, there are androgen receptor degraders in prostate, but we already had SERDs. So, we asked the faculty, because it looks like vepdegestrant data looks very similar to SERDs, except it came along later and less follow up. But we asked the faculty if vepdegestrant was available, would you use that or oral SERD? Everybody says oral SERD first. Any thoughts about that in the future of Protax, Virginia?
I think Protacs in general are going to be very useful. And remember, Protacs are not necessarily just ER degraders. They could be degraders of any protein. So that's the benefit that you're going to see other drugs in the future that are Protacs. This was a consensus from all of us, which I think is probably the first one to see, which is what we would do. We've had experience now with elacestrant for 2-3 years. We have experience with imlunestrant for almost a year. So it's hard to pick Vepdeg as the first oral anti-estrogen we would use. But if a patient cannot tolerate the oral SERD, then I think switching to Vepdeg would be a strategy that many of us will end up doing.
Sara, would you like to see vepdegestrant available? And again, where do you think it's going to fit in the future?
Sure. I like having options for patients because it's nice to be able to switch among them and see what is more tolerable. I think people were disappointed because we didn't see this huge differentiation in efficacy that we expected with this novel mechanism of action. But it was a positive trial, similar to the other ones and on the same order. It's just that we've been spoiled a bit with the results we've seen from other studies.
All right, let's get back to another case. We're going to get into a little bit of capivasertib. Virginia, you have a 65-year-old woman. What happened with her?
Yeah, so she was started on an anastrozole in the first-line setting, but she was not able to tolerate it and decided to stop it herself. So she presented in the metastatic setting now. She was receiving palbociclib, denosumab, and exemestane. And then after 18 months, she was found to have progression of disease. She had ctDNA that showed a PIK3CA mutation. And so at that second line, I decided to give her capivasertib and fulvestrant, and she did really well with that. She had some diarrhea, which is pretty common. And one of the things that I've seen, not with this patient, but with other patients, if they have enough diarrhea and they don't do what Sara's patient did, hydrate, then they end up becoming hyperglycemic because of the dehydration. And that starts a whole vicious cycle that many of these patients may end up hospitalized. So very, very important that these patients are monitored actively at home.
Sara, any comments on your experience with capivasertib? Also, I was going to bring up before with Virginia's case with the elacestrant that the patient had a partial response, which I was curious how often you actually see people respond either to a SERD or to capivasertib. So any thoughts about both of those questions, tolerability with capivasertib, and do you see partial responses either with that or also with SERDs?
Yeah, with the SERDs, I actually was involved in the studies with vepdegestrant and saw some really nice partial responses. So I do think, again, patient selection, we're still learning, but for some patients with endocrine sensitive disease, we actually are seeing responses. In terms of the capi, I haven't had great luck in terms of skin toxicity. It's really important that we use the antihistamines from the get-go, but in spite of that, I've had several patients develop significant rashes. And so that's something that I've, anecdotally have struggled with. One patient I had to switch to everolimus.
So I think everybody's pretty familiar with the Capitella phase 3 trial, the 291 study that led to its approval and its use as we are discussing here today. Any other thoughts you have about the tolerability issues, Virginia? And also, with this 4 days on, 3 days off, do you see difference in how people feel when they're on and off the drug?
Yeah, we definitely do. And so you'll see patients at that fourth, fifth day having the worst toxicity, and then it kind of gets better right in time for them to start all over again. So that becomes a little hard. And also the scheduling, even though we would think it's easy to say 4 days on, 3 days off, please don't screw that up. How many patients will end up taking it for more than 4 days, which gets them into trouble. One other thing I want to mention with diarrhea, we talk about grade 1, 2 versus 3, 4, but grade 2 diarrhea is up to 6 bowel movements above baseline a day. So this is not just trivial diarrhea. This is really affecting the activities of daily living. So grade 2 diarrhea should be taken very seriously.
So, Sarah, question in the chat room from Gandhi. Do you need to use a GnRH or ovarian suppression when you give a SERD? I know there's some data out there that says maybe you don't.
Yes, you should. And Virginia and we were talking about this a bit earlier. There is a risk of ovarian cysts in premenopausal patients on oral SERDs without the ovarian suppression. So that's something that should be considered, and it is being studied to see if it's necessary. There are some studies looking at individually whether it's necessary.
So, Virginia, one of the most interesting questions we've been asking the last few years since this whole new scene sort of evolved is the so-called double mutation situation. The patient has both ESR1 as well as PIK3. I've been hearing different things about how people make that decision. I couldn't even begin to come up with a consensus statement on how you all approach this. Here we said, we tried to tease out, we said, okay, the patient's been on CDK for 2 years, so they're sensitive. They're doubly mutant, but they have symptomatic liver and bone mets. You can see some people are comfortable with SERD, some with CAPI. We say they're asymptomatic. Kind of looks like people sort of do the same thing. I've heard people say there are different factors they consider, whether it's an earlier relapse, et cetera, the later relapse. I haven't been able to actually figure it out. You want to help me figure it out? Virginia, how do you make the decision?
So there's subset analysis from Emerald that has looked at this patient population, and it's actually not as rare as you would think, because around 40% of patients will have an ESR1 mutated tumor at some point, and 40% will have a PIK3CA mutated tumor. So around 25% of these patients will have a double mutation, so not rare at all. So the data with all of these trials, again, the cross-trial comparisons that we love, are showing a median PFS of 5.5 months, regardless of what strategy you use, whether it's a combination of a PI3 kinase inhibitor plus endocrine therapy or single agent oral SERD. So personally, I like giving the oral SERD just because it's easier to tolerate. Now, in a patient with symptomatic liver metastases, that gets a little tricky. So I think, Sarah's point of capivasertib might be a little safer, but in asymptomatic disease, I'd feel very, very comfortable giving an oral SERD.
Sarah, would you like to tell us your secret sauce?
I think Virginia said it really well. I don't have anything to add. I do think we're excited to see oral SERD with PI3 kinase pathway inhibitor combinations, and that's sort of the next era that we are hopefully entering soon.
So, Virginia, our way of doing consensus is a conference is everybody says the same thing. We call it a consensus. If we get 3 different answers, we say, no, it's not a consensus. But here we say just PIK3 positive. There's no alpelisib. Alpelisib went away pretty early along the way, and we started to see everybody giving the same answer. But then when we start bringing it back down to, okay, they're PIK3 positive, but they relapse after 10 months, you start to see TDXD and capecitabine coming in, but still people using this approach. I want to finish out. Actually, Virginia, I want you to give a second opinion because Sarah's going to see this patient next week. I'm not sure she's decided what to do, so maybe us and maybe even the audience can give her some help. So what's the deal here with this 67-year-old lady, and what are you thinking as you start thinking about seeing her next week, Sarah?
Yeah, so she's 67 and has an ESR1 mutation, PIK3CA wild type. She's received ribo and fulvestrant for just a year, but is progressing in the liver with symptomatic bone metastases, but her liver function is normal. So I'm just wondering what I should start as I go through the options. I'm thinking about the giredestrant everolimus data from the Avera study, which is not yet FDA approved or available, but I would love to be able to use that. And then we can think about studies looking at switching the CDK4/6 inhibitor. But she has an ESR1 mutation, has just had disease progression on fulvestrant. So could we do a CDK4/6 inhibitor with an oral SERD? As Virginia noted earlier, we don't have the approval of abema imlunestrant yet, but that would be an option based on EMBER-3.
Was she a de novo or she recurred?
She was de novo.
Right. Okay. So she never had chemo because chemo, I guess would be an option, or TDXD. She's HER2 low. Before we get Virginia's thought, anything you want to say about her as a person? Is she kind of all over this and looking things up? Is she, any background, or more like just tell me what to do?
She's more of a just tell me what to do. I see more of that in our area because we're surrounded more by rural areas, and so it's a different flavor in terms of the patient take, although there's still a lot of patients who come with all their research and open AI help. But yeah, she's very willing. She actually wanted to take the fulvestrant frontline rather than an AI because she liked the idea that she would only have to be responsible for taking the ribociclib. So,
that's interesting.
Yeah.
Yeah. That's interesting. She started with fulvestrant. I'm guessing you saw a lot less Tell Me What to Do when you were in Los Angeles at UCLA?
Yes, this is a very different patient population.
Well, you slowed down, hopefully. But anyhow, okay, Virginia, second opinion, what do you think?
I think this would be a nice patient to try to get imlunestrant and abemaciclib approved for. I agree. The ESR1 mutation is something we should use to treat the patient's cancer. At the same time, 1 year of metastatic first-line ribociclib is making me a little uneasy. So I'd really assess how she's feeling. If the symptoms are pretty severe, then starting with a short course of chemotherapy may actually not be a bad idea for this patient.
So I think we're kind of coming to the end here. We got a bunch of questions coming in from the chat room. But Sara, somebody's bringing up this issue of a press release on a Persevera study of giredestrant as palbo, first-line treatment being negative.
Yeah, so...
Any thoughts about that one?
I'm not personally aware of I wasn't part of the study, so I can't speak to it with knowledge, but I can tell you that we see positive and negative results come through. And as we look at the full data, when it's presented, try to make sense of it. But sometimes studies are negative. I don't know if Virginia has a more eloquent way of stating that.
Yeah, I wasn't too surprised because this is first-line CDK plus an oral SERD, and we know that the CDKs are just so powerful. I feel that the endocrine partner may not matter as much, and I think that's probably what we're seeing, but it'll be important to see the data.
Well, like I was saying about with PD-1, there's a bunch of other studies out there that we're going to see in the next couple of years, so we'll see if they're all negative or maybe we'll see some positive, and then we'll be scratching our head as always. Anyhow, Sara and Virginia, thank you so much for sharing your thoughts and perspectives tonight. Audience, thank you for attending. Be safe, stay well, and have a great night. Thanks so much, Sara. Virginia, thank you so much. Have a great night.
Thank you.
Subsequent to the recording of this program, the FDA approved vepdegestrant on May 1st, 2026 for adults with estrogen receptor positive epidermal growth factor receptor HER2 negative ESR1 mutated advanced or metastatic breast cancer as detected by an FDA authorized test with disease progression following at least one line of endocrine therapy. This approval was based on the results of the VERITAC-2 trial.